Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Joe Kvedar. Dr. Kvedar is Vice President, Connected Health at Partners Healthcare in Boston, where he is leveraging personal health technologies to improve care delivery and help providers and patients better manage chronic conditions, maintain health and wellness, and improve adherence, engagement, and clinical outcomes. And he's been working on this at Partners for over 2 decades. He chairs the Connected Health Conference. He's an advisor to investors in the connected health space, serves on a number of industry boards and committees, and in his spare time, he has managed to write 2 books on the subject of connected health. The New Mobile Age, How Technology Will Extend the Health Span and Optimize the Lifespan, and The Internet of Healthy Things. He also blogs at the C Health blog, and you can find him on Twitter at @JKvedar. Welcome, Joe, and thank you for joining us.
Really excited to be with you, David.
Excellent. So I am going to kick things off by asking you about digital therapeutics. I'm interested in the term. How do you see digital therapeutics helping to manage health of populations with less of a high touch, high cost sort of interaction with the traditional healthcare system? And I think first off, maybe I'll ask you to define digital therapeutics. What's the role that you see for digital therapeutics today?
Well, it's a really exciting area. So the idea here is that when we think about illnesses, let's take surgery and put it aside for now. So procedures and surgery we won't think about, but medical interventions for illnesses usually involve some sort of a compound, a chemical, a protein, something you ingest, something you inject, something you infuse, and those are therapeutics. And we don't even think in the 21st century as much as we probably should, and be thankful that you can take a pill at every evening and your blood pressure will go back into shape, most of us, or your cholesterol will, or what have you. The idea behind digital therapeutics is, could we use digital interventions, be they wearables, mobile apps, virtual reality, combinations of those things? Could we use those to achieve outcomes in illnesses that either rival or exceed chemical therapeutics? And would that be a good thing? First of all, could we do it? I'll share a couple of examples quickly that illustrate that we can. And why should we? And I think that latter question, if I'll go to that one first, if you'll give me that we can do this, leap of faith.
Okay.
Why should we? And that has to do with the economics of developing and pricing pharmaceuticals versus the economics of developing and pricing things like software. And I believe that we are in a conundrum in the US in that we do spend a lot of money on medication. Of course, that's for the people taking the medications, most of the time that's a good thing. And the pharmaceutical industry is kind of hooked on that, let's say, crack cocaine of the high profit margins they get from developing chemical therapeutics. If we could achieve similar outcomes with something that was low cost and ubiquitous like a mobile app, I think societally we would have a better shot at lowering the cost. We all know that software can be a lucrative business as well. It may not have the margins of biotech and pharma, but it's got very good margins. And if done well, it can create companies like Microsoft, Google, et cetera. And so that's the thought behind digital therapeutics is, could we get to a state where instead of saying, David, for your high blood pressure, take this pill every night, we'd say, download this app and use this tool for your high blood pressure. Sounds a little bit futuristic, but we've done this. For instance, we have a project now that's a collaboration with Samsung. We've been working on it for many years, where we take in some data about you from your mobile device and a wearable, some data from the environment, and we mash those data up in a machine learning environment. And every day you get an automated, contextual, inspirational message encouraging you to be more active. And when we put people with type 2 diabetes on that program for 6 months compared to a control group, their diabetes got better. We also saw the same effect when we put teenagers with asthma in a Facebook group. The social connections of being in a Facebook group correlated with improvements in their asthma without any changes in drugs. So those are two quick examples of how digital therapeutics might work. And as I said, it only really will be valuable if we can prove that we can do it at a net lower cost and get at least as good outcomes, if not better.
Right. And the cost is being measured in a couple of different ways these days. We have our traditional fee-for-service approach to thinking about cost, but we're moving as an industry, as a sector of the economy, into the notion of value-based payment. Although to be honest, I'm not sure that I see how we are going to get there, how we are going to succeed in the value-based model. In a sense, many of the value-based models are really just a budget management overlay to a fee-for-service model. And yet we're sort of moving in this direction. And I guess I wonder, does the notion of digital therapeutics, does the notion of virtual care, the notion of telehealth work in one of these payment models better than in the other? It seems to me, at least on the face of it, that to the extent we're thinking about cost savings through using digital services, that seems to be an advantage in a fee-for-service model. Would you agree? Would you disagree? Do you think there's a value-based approach where this supercharges the approach to value-based care, or
Yeah,
what?
I think it can work in both. So let's talk through how that might happen. So when you lump two or three things together, which I think are different iterations. You
Okay.
mentioned virtual care, telehealth, digital therapeutics. They are slightly different in their impact. For instance, telehealth is very good at extending access. And so if you believe that access to services improves outcomes, it should work in a value-based environment, because the value-based environment is about valuing outcomes over units of service. And we certainly have done things with remote monitoring, for instance, monitoring patients with congestive heart failure in their home. We can show how we reduce readmissions, we improve mortality, we actually reduce the total medical expense for those patients by simply monitoring in their home with a weight scale, blood pressure cuff, and a nurse call center interacting with them periodically to keep them healthy at home. The hospital emergency room and the hospital inpatient service are the high cost parts of the system. So with any of these chronic illnesses, if you can use these technologies to keep people healthy in their home, you stand a chance of winning in a value-based environment. One of the challenges, though, and then I'll go to fee for service. One of the challenges in general with a value-based environment, you actually hit the nail on the head with this, is that we still ask our providers to document their work by billing codes. And even if their organization is being paid on a risk basis, the people that are doing the actual work on the ground level are still billing codes, and most of them are still in incentive arrangements that value volume of service. So it's a little bit of a schizophrenic world. We are making some progress. We have some examples. Of course, Kaiser Permanente is one where they've been at this long enough now that they have figured out a way to manage all of that. But in other situations, some of our risk contracts here, for instance, at Partners Healthcare, we're able to experiment with things like compensating primary care doctors by panel size and not by actual units of service. And we have some practices that are set up to take care of employees that are purely paid directly by the institution, so they don't have the overhead of having to worry about billing codes and things like that. So there's some experiments going on, but largely you raise a really good point. So
Yeah,
just
I think that, as you allude to here, there are probably optimal payment solutions that will vary by type of provider or care setting. And we seem to be, as a rule, trying to fit everybody into one system or another at any given time. And to me,
yes.
that seems to lead to the partial successes or failures that we've seen.
Telehealth, particularly the remote monitoring, more efficient to telehealth, whether it be monitoring illness, people with chronic illness in their home, or doing these quick asynchronous e-visits that we often do with patients now, exchange what would be the equivalent of a text message. Of course, it's done on a secure platform, so it's not texting, or if it is texting, an app. Those kinds of things can add value because they increase efficiency and they should improve outcomes, and that's what wins in a value-based environment. Turn it around in a fee-for-service environment, and you can use the same tools, but if you're using them to extend access, then you're going to get more units of service. And as long as you have payment systems in place where whoever's paying the bill agrees to pay for these virtual services, then you can use them in a fee-for-service environment to extend basically your market share and extend your market presence to other geographies. So both can work, depends on how the payer views it and what your relationship with the payer is.
You mentioned billing codes a little bit ago, and I understand you're involved with an AMA advisory group, the Digital Medicine Payment Advisory Group. That's intriguing to me. I imagine that somewhere at the end of this process will be some new codes designed to define and serve as a vehicle for reimbursement for certain digital services. Have you gone down the path far enough to say anything more about that?
Sure, I'm happy to. We've been in existence a year and a half, and we actually did put through the CPT editorial panel. Maybe I should back up and do just a very, very quick tutorial on how these codes work for your listeners. So the reason
Joe,
codes...
before you do, I'm going to interrupt you for a second for our station identification. If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Joe Kvedar. We're talking about codes, reimbursement codes for digital health services.
Thank you, David. So yes, we were talking about the AMA's work in the area, and I thought it would be worthwhile explaining a little bit about how coding works. And as a provider, if I, in a traditional, forget digital for a minute, but you come see me as a patient, the way I get paid is by submitting to an insurance company a unit of work that's defined by a code. And that code is usually combined of three things: the amount of time I spent, the complexity of the medical work, and then the cost of running the practice. Those are the three components that go into how much money an insurer pays for a given service. I mention all that because for years we talked about value-based payments a little while earlier, I continue to be very enthusiastic about that space. But I alluded to this earlier. It occurred to me a little while ago that even if we have an ideal value-based environment, if we still expect people at the ground level to document level of activity and effort via codes, if that's how we're going to document that I came in with the office or whatever I do and did a day's worth of work, if I can't code virtual health, I'm not going to do it. It doesn't matter if it's value-based or not. I have to be able to demonstrate that I did some work. So I got enthusiastic about this as a way to move provider adoption forward. So with that background, the committee was formed. We've been working now. We're in our second year. And our first codes that we put through were on two things. Again, I think they will be very transformational if they end the journey, and I'll tell you about that in a minute too. One was for remote monitoring evaluation and another one for setup. So two on remote monitoring, and then one on physician-to-physician consultation over an electronic record, so that if you, as a primary care doctor, I'm a dermatologist, if you sent me a little bit of history and a couple images of one of your patients and I reviewed those and gave you some sound advice, hopefully that there would be a way for me to get compensated for that work. So those two codes went through a process around last fall called the CPT editorial panel. There's another separate process after that where a combined group that assigns a numeric or financial value to them. We don't know the outcome of that yet. And then the Medicare administrator, CMS, Center for Medicare and Medicaid Services, decides if they're going to put the codes into practice. And we expect We've heard good things from Medicare on these. We've been in communication with them. It's not a done deal, but we expect that by January of 2019 that these remote monitoring codes at least will be in place. So that's a lot. And for someone who's not in the thick of it, it's a lot of gibberish. But as I said, the thing to take away from it is if we have ways for people who do virtual care to document that they did some work, I think it will go a long way to helping us ensure provider adoption, whether the payment for those services is through a fee-for-service mechanism or whether the organization is being held accountable at a risk level. In order for people to do that work, they need to be able to document that they did the work, and that's what the codes allow us to do.
There's sort of several layers of chicken and egg problems here in terms of adoption. And one layer of the problem is that for many people, many patients, particularly older patients, tend to do what their doctor recommends. And if a doctor is not getting paid for a certain type of service, then he or she is less likely to recommend that service, perhaps. So it sounds like you're moving at the other end of this chain, so to speak, getting that reimbursement into place or teed up to be in place so that then payers and then healthcare providers can more fully recommend these services to patients, and then patients can continue to adopt them. Because, I mean, correct me if I'm wrong, but my sense is that despite the strides that have been made in terms of technical advancements, the adoption of some of these technologies is pretty limited overall.
It is. There's data from a 2016 AMA survey on their members that I like to quote. This is provider adoption. You hear a lot of different, like you'll hear about, 80% of people said they'd be willing to email with their doctor or something like that. And those are important and valuable. And I would say, generally speaking, most of our challenge in moving connected health forward is not on the patient side. Most people these days consume so many services through mobile channels. Many are wondering why they can't consume more healthcare that way. So just again, generally, there's some exceptions to that. But it's more on the provider side, and which is one of the reasons I started devoting more energy to it. And so, yeah, enabling healthcare providers to have both workflow and reimbursement options that support these new kinds of tools will help ensure their adoption without a doubt. The AMA survey data that I was referring to, for instance, across specialties, about 7 or 8% of doctors now use some form of remote monitoring, whereas virtual video is more like all comers, about 20%, and you can sort of break it out by specialty, by small practice, et cetera, whereas even for remote monitoring, all comers about 10%. So the adoption of virtual visits, if you will, is about double the adoption of remote monitoring. Both are still relatively low.
For a number of reasons, I suppose. You've written some about the challenges inherent in caring for a larger, older population as our older population nationally and globally grows, and as we encounter more chronic conditions. And as we're sort of dealing with chronic conditions in a system that I suppose has been built or historically existed more to deal with acute situations or injuries. That's what it's been optimized for. And it seems to me that this is just one of a plethora of issues that we have to deal with in order to make this change, to make this shift, in order to do it in a cost-effective manner. I wonder if you could speak to other aspects of this problem aside from the last mile of the communication between clinician and patient on any given day.
Well, thanks for asking. There's so many challenges with our aging demographic, and I want to be, even I just said challenges. I think we should all start by celebrating the fact that over the last century we've added 25 years to our lifespan. We have a full, on average, quarter century more of life than we did 100 years ago, and that's because of all of those acute care innovations you just alluded to, whether it be heart attack treatments or cardiac surgery or neurosurgery or statins or better kinds of drugs for blood pressure. It's all done a wonderful thing for us, better cancer treatments.
Right.
But
So let's call it an opportunity and not a challenge, right?
yeah, but we haven't done really anything as a society to ask the question of how we're going to get anything out of those extra 25 years. When Social Security was created and started at 65, the average lifespan was 62. So if you made it to 65, you got a little bit of reward for what? I don't know, 4 or 5 years. That people by that time had outlived the average lifespan. The average lifespan now is 78, 80 years old. And we still, when you're 65, we pat you on the back and say, well, I think you go play some golf, or maybe you like bridge, but you're going to become a burden to society, and just go off and do it. People that are older have wisdom, that they have their mentors, that they have experience, judgment, all these things that come with age that we uh, really don't make an effort in society to bring on. And the flip side of all that is that we know that a sense of purpose is a very strong predictor of longevity. And so having those skills and having no one ask you for them is really a tragedy. And I know that's a very high level, sort of squishy concept, but people with a sense of purpose, and this is all research done by a fellow called Eric Kim at the Harvard School of Public Health. People with a sense of purpose have fewer doctor visits, they have fewer hospitalizations, they get more preventative tests. They keep themselves healthier because they get up in the morning knowing that they've got to get something done, and if they're not healthy, they can't get that thing done. That can be, by the way, watching the grandchildren, but it could also be contributing in a part-time job as advisor, mentor, board member. Lots of different ways of having a sense of purpose, but we don't do a good job of that. We also, another big lever for handling health span is social connection. And we know that isolation is just as bad as a 15 cigarette a day habit. It gnaws away at people. People are much less healthy if they're isolated. So we need to do better. And we've done some as a society, but we need to spend more energy getting people connected. And technology, of course, can play a role there. And then finally, a little bit of physical activity is helpful too. And so once again, technology can play a role vis-a-vis wearables and inspirational mobile apps that help keep you engaged with your wearable and things like that. So those three simple things alone will help us fill that health span. If we do it right, it'll also give us a workforce to contribute, maybe not, and hopefully not full time, but in some level. We're going to run out of young people. 2020 is a very important milestone because that for the first time in history, we'll have more people over 65 than under 5.
Hmm.
And that continues to grow. By 2050, there will be 16% of the world's population that'll be over 65. Right now, it's about 6%. You can do the math. If we continue to deliver care where the only way you can get care is, then we won't have enough of people like me to go around. We're just going to overwhelm the system with older people. So we have to start these one-to-many care models, these sort of home monitoring for chronic illness models, these, as I alluded to earlier, mobile apps, things like digital therapeutics, so you don't even need to see a doctor because you're doing well, for us to deal with this so-called silver tsunami.
Right, the silver tsunami. Well, we're on the leading edge of that now, and it sounds like it will be more fully expressed as time goes on. So there's certainly a lot of work to be done. As this continues, Joe, I'd like to ask you, just as we finish up here today, if if you were to wake up and find yourself further down the path here, if you were finding yourself 5 years in the future, is there one thing in healthcare that you would hope or predict has changed dramatically?
5 years is a short time in healthcare innovation. We tend to innovate in long cycles, and that's one of our challenges. So I don't know how different things will look in 5 years. One of the things, though, that I am interested in now is because of all the, some of it appropriate, but all of the rage about artificial intelligence, both the controversy and the excitement. One of the things that I keep trying to remind folks is that if we integrate technology in the right way and we're thoughtful about it, we'll create the opportunity for your doctor to be more of a human being and to take better care of you. Most of us as healthcare providers nowadays are overwhelmed with non-caring tasks such as data entry, prior authorization, the list goes on and on. And so we get frustrated because we have, in order to meet the demand, we talked about the silver tsunami. In order to meet the demand, we have to see patients at a fair clip. There's not enough of us to go around. And during the time we're with you, we have to do things like type and stuff like that. So other industries have managed to do things like, for instance, when you go into the Home Depot or any retail outlet, really, there's 5 or 6 self-checkout cashiers and one person. And if you don't need that person, you just put your SKUs on the reader and your credit card in and you move on. But if you need that person is there. We don't do that in healthcare. You always see a person. It's always one-to-one. That's what I'm looking forward to us starting to adopt in the next few years. 5 might be ambitious, but it might not, because there's so many people doing so many interesting things now with chatbots and other kinds of artificial intelligence tools that maybe within 5 years we'll see something. And I predict if we do, it won't be from a traditional healthcare provider. It'll be from a CVS, a Walgreens, a United Health Group. Someone like that will leapfrog and start to put some of this stuff in play and capture some of the chronic illness and primary care market and probably take it away from us as healthcare providers.
Very interesting. Well, humanizing healthcare through the adoption of technical tools. Thank you, Joe. I appreciate your taking the time to speak with us.
It's been a pleasure being with you today, David. Thanks.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.